25-year-old female with a history of medically persistent, intractable seizures treated with 3 medications. 1. What is the diagnosis? 2. What is the cause? 3. What is the clinical presentation? 4. What image modality is used? 5. What treatments is the best? 1. What is the diagnosis? Mesial temporal sclerosis (MTS), also known as hippocampal sclerosis. 2. What is the cause? The exact cause of MTS remains controversial. Prolonged seizures or complicated febrile seizures during childhood may lead to MTS. Some epileptogenic agents can induce MTS and spontaneous recurrent seizures in adult animals, with the mechanism involving excessive excitability due to the release of excitatory amino acids. This leads to prolonged depolarization of neurons and the entry of cytotoxic amounts of calcium. 3. What is the clinical presentation? Patients with MTS typically present with complex partial seizures, often preceded by auras involving sensations such as déjà vu, fear, or epigastric rising. Seizures may include automatisms and dystonic posturing. There is often a history of febrile seizures or other precipitating events during early childhood, followed by a latent period before the onset of epilepsy. 4. What image modality is used? Coronal volume and coronal high-resolution T2WI (FLAI) are best to diagnose mesial temporal sclerosis. Findings include reduced hippocampal volume, hippocampal atrophy, increased T signal, abnormal morphology, loss of internal architecture, interdigitations of hippocampus, stratum radiata, a thin layer of white matter separates the dentate gyrus and Amen horn. Anatomy of the temporal lobe and hippocampus. Five. What treatments is the best, if considering surgery, depends on baseline neuropsychological assessment, good evaluation, risk of deficit, bad evaluation, less risk of deficit, medical refractoriness to or more, dominant hemisphere considerations, VADA test or functional MRI. Stimulation modality treatment, vagus nerve stimulation VNS, responsive neurostimulation RNS, deep brain stimulation DBS. Vagus nerve stimulation, pros, option for patients who failed resective surgery or not a candidate. Epileptogenic zone localization is not required. A 50% or greater reduction in seizure frequency, cons, seizure freedom is rare. The results for VNS are clearly inferior to resective surgery. Possible hardware complications, need for battery change. Responsive neurostimulation, pros, option for patients who failed resective surgery or not a candidate. Substantial reductions in seizure frequency. Intermittent stimulation, so longer battery life and less side effects. Cons, seizure freedom is rare. Epileptogenic zone localization is required. Need for battery change. Deep brain stimulation, bilateral anterior thalamic nucleus, pros. Option for patients who failed resective surgery or not a candidate. Epileptogenic zone localization is not required. Reductions of seizure frequency 40% acutely and 50 to 69% after several years. Cons, seizure freedom is rare. The maximal effect seen typically 1 to 2 years after. Implantation, possible hardware complications. Surgery treatment, anterior temporal lobectomy. Selective amygdalohippocampi. Anterior temporal lobectomy, pros. Significant seizure freedom and improved quality of life. Cons. Risk of neurocognitive disabilities including verbal memory and naming following ATL in the dominant hemisphere. 3 to 4 centimeters, dominant hemisphere. 5 to 6 centimeters, non-dominant hemispheres. Collateral eminence, supralateral limit. Performed for disconnections, lateral, parahippocampus. Anterior, through the amygdalohippocampal sulcus, until the choroidal fissure is reached. Medial, crural and ambient cisterns. Posterior, tail of hippocampus and the fornix. 3 cm of hippocampus should be resected. Selective amygdalohippocampi. Pros. Possibly improved neuropsychological outcome. Possibly less risk for verbal memory decline after left compared with left ATL procedure. Controversial. Cons. Slightly worse seizure outcome compared to ATL. If this patient has right hemisphere dominance, what strategy would you use? A. Anterior temporal lobectomy. B. Bilateral anterior thalamic nucleus stimulation. C. Selective amygdalohippocampi. D. None. B. Bilateral anterior thalamic nucleus stimulation.